Hi, it's Dr. John Raymond Baker, DC, and it's Friday, May the 2nd, and on Friday I usually make my rant videos, so you're in luck, or not. Actually today I want to cover a topic that has kind of been a pet peeve of mine for some time, and that deals with the notion of best medical practices, current medical guidelines, evidence-based health care. You know, the same old BS that you encounter if you're a doctor all the time. Now, what patients might or might not understand is that doctors, myself included, are expected to follow these evidence-based guidelines, best practices, whatever euphemism you want to call these cookie-cutter outlines to tell you how to practice. And if you don't, then you're considered not practicing within the standard of care, I think, sometimes. And actually, a lot of these guidelines, the word guidelines means serving as a guide, not a rule, not a law. But a lot of people here in Texas and other states treat these as if they are law, as if they're, carved on tablets and brought down from the mountain by Moses. But I wanted to kind of show you or highlight to you today, both professionals that watch my channel and lay people, patients, that how crazy these guidelines can get. Because I live in the real world. I'm not, some of these people that are crunching numbers to try to save insurance companies a buck here and there by causing additional pain and problems for patients. So I found this in 2011, and it's an article that talks about clinical practitioners not adhering to evidence-based guidelines for osteoarthritis. Now, osteoarthritis is a disease in which the joints wear out. That's basically it. It's a type of arthritis that's different from rheumatoid, where in rheumatoid your joints flare up, sweat, you have the inflammation signs, rubor, dolor, tumor, and color, heat, pain, swelling, and then eventually functio laesa, which is loss of function. But anyway, this is from 2011, and honestly I don't think things have changed dramatically since 2011. This is 2014. But before I go into it, I wanted to say that as a kid I went to an MD. And in fact, that's the only health care I thought was the quote-unquote legitimate, real doctor health care. And a lot of times he would give me shots and pills for a viral problem, and I didn't know any better. And a few years ago it was found that despite doctors, MDs and DOs being told that viruses don't respond to antibiotics, quit giving them, you're causing more and more bacteria that are becoming multiply resistant, they continue to do so, much to the frustration of these clinicians. So this says, anyway, so what I was trying to say is that back then, and I think still today, you went to a doctor for a script, for a prescription. You expected him or her to have superior knowledge about disease, figure out what was wrong with you, and write something to fix it. And I think that's still, the way it is today, and people who leave without a prescription don't feel like they've had a valid medical transaction, or at least the people I know. Anyway, so I'm going to be referencing this article. New research found clinicians who care for patients with osteoarthritis, in parentheses OA, are likely not following standard care guidelines that are based on current medical evidence. And I really wonder sometimes where they dig up this current medical evidence. Researchers noted physicians were prescribing medications for pain and inflammation. Oh, heaven forbid that you should give a script for pain and inflammation, which is the highlight of people that have various kinds of arthritis, are opting for surgical interventions rather than, get this, recommending weight loss and or exercise programs to osteoarthritis patients. Details of this study are available in January 2011 issue of Arthritis Care and Research, a journal published by Wiley Blackwell on behalf of the American College of Rheumatology. Now, basically and I'll reference more in this later, but basically what they're saying is, hey, you don't need to give them prescriptions. you need to tell them go home, do exercise, and lose some weight. Now, let me jump back to this. A 2002 report by the World Health Organization estimated osteoarthritis to be the fourth leading cause of years lost due to disease worldwide. Now, I'm not sure if they mean years lost to disease, meaning that your life is shortened or your productive life is shortened, or exactly what they mean by YLD, but that's from the article. OA disability is quickly becoming a major public health concern, with experts suggesting that by 2020, and since we're in 2014, that's just 6 years from now, the number of people with osteoarthritis will have doubled due to growing obesity prevalence and the aging of the baby boomer generation. According to the Centers for Disease Control, CDC, arthritis and other rheumatic conditions, well, there's osteoarthritis, I don't know why there's rheumatoid arthritis, but there's osteo, and osteo is not generally an inflammatory condition. But anyway, it cost the U.S. $128 billion in 2003, a 24% increase since 1997. Much of the cost burden in arthritis care can be attributed to OA, which accounts for a large volume of surgical procedures, including total joint replacements. Now, I want to kind of take a break from the article and talk about a real world example. Let's say you've got a guy that was either a professional football player, wrestler, or just a big guy that's worked hard and had a lot of falls and things through his whole life. He comes to you with bum knees. And when I say bum knee, I'm talking about the cartilage worn out, femur is right on sitting on the tibia. We're talking bone on bone. He says, Doc, I'm just dying, man. I just can't hardly walk anymore. You need to help me out here. Give me some pain medicine, something for inflammation, something. Because I can't even hardly walk to the truck anymore. Now, that's a real world example. Now, if you're the doctor sitting across from this big 300-pound, 6'5" guy, are you going to tell him, listen, buddy, you just need to lose weight and go out and exercise. Have a great day. Bye. You could get some serious blows from that. And I mean, like noggin thumping, as we call it here in the South. And really, are you doing him that much good to tell him, look, go buddy, lose some weight and get some exercise? I mean, after you're 30 years old, especially when you're my age in your 60s, it's really hard to lose weight. And it's not something that's going to happen overnight. And even with your best efforts, you might lose 5 pounds in a month or something like that at my age. And the fact is, often exercise, walking, running, jogging, all kinds of weight-bearing stuff is going to be something that's going to be interfered with if you got bum knees, if you got bad knees, if you got bone on bone, bad osteoarthritis. Even if you don't have that level of degeneration, if it hurts like hell for you to walk, are you really out going to be walking several miles? You know, I mean, most of us live in the real world where we have jobs, we have limited time to exercise anyway. But if it hurts you to walk to your truck, where's the compliance if you tell them, I need you to go out there and run about 5 miles? And really, if you're running on a knee that's worn out, you're going to be put a lot of shearing forces on there, and you're going to accelerate what's already messed up. So, you know, this best practice is telling folks that you need to lose weight and exercise more if your knee's worn out. That's where I have a problem with these cookie cutter guidelines that are clinicians that sit around crunching numbers and figuring out ways to often save insurance companies money. You know, a lot of these studies and programs and all that, if you look deep enough, you're going to find some insurance company's name that's funding the original research of which these outcomes are based. And honestly, clinicians, for all the ethical guidelines, are going to be buttering. They're going to know which side of the bread they're buttered on. In other words, what's expected to them to come out of their studies. They're not just living in some sort of airy-fairy world where, it's whatever you find on the study's fine with us. We're paying hundreds of thousands of dollars for this study, and oh well, if it comes out against us and hurting our product or hurting what we do, so be it. Now another issue, and this one I do have to kind of go along with, is that there's far too many arthroscopic knee surgeries for osteoarthritis, especially with older folks. What they found in a study that was done double-blind a while back was that sham knee surgeries, where they do everything to make the person think they've had a real surgery, except they don't do the arthroscopic clipping inside the knee, they found there was no difference between a sham knee surgery and the real knee surgery. So the conclusion was that it's really of no benefit if it's not any better than what someone gets from a placebo effect because they think they had the surgery. But let me jump down to here. It says Dr. David Hunter from the University of Sydney in Australia, New England Baptist Hospital in Boston, Massachusetts, and colleagues reviewed how standard clinical practice diverges from evidence-driven recommendations in the management of osteoarthritis. We present a potential roadmap for optimizing the quality of OA healthcare for those developing and enforcing policy decisions. In other words, saying when you can get things done and when you can't get things done. And for clinicians on the front lines of OA management to enact practice change. In other words, to make people quit doing surgeries, quit giving meds, etc., just telling people go exercise, lose weight, buddy. Bear with me just a sec. The authors report that therapeutic interventions are primarily aimed at reducing pain and improving joint function by using therapies that target symptoms, but do not facilitate improvement in joint structures or long-term betterment of the disease. Frequently, physicians do not recommend conservative non-pharmacologic management therapies, which leads to unnecessary diagnostic imaging and inappropriate referrals to orthopedic surgeons. Look, if you got a guy that's out, he's a weekend warrior, he goes out and says, "Hey doc, look at my knee, man, it's all swollen up." He says, "I heard a pop when I dove to tackle somebody on the weekend playing touch football, and now it's killing me." What are you going to do? Do an x-ray to see whether or not the meniscus is torn or whether it has a bucket handle tear? No, you're going to have to do an MRI or a CT, and the MRI, in my estimation, is preferred method. I've been doing healthcare since 1989, so this year it'll be 25 years, and I've seen my share of bad knees, and sometimes the only way you're going to fix it, if it's really worn out, is surgery. I don't like surgery. I think surgery should be the last end of the line destination. Everything else needs to be stop here, stop here, stop here. Conservative management, even pharmacological management in conservative fashion. Before surgery, you shouldn't put surgery as the first thing. But sometimes, if a house is torn up really bad, paint ain't going to fix it. The best paint in the world is not going to fix something that's rotted to pieces. And in essence, we're talking about degeneration and deterioration, the joint's version of rot. Researchers further suggest that surgery be resisted when symptoms can be well managed by other treatment methods. Well, if they're well managed by other treatment methods, why are you going to consider surgery? That's kind of an obvious point. Based on current guidelines, imaging should be reserved for instances when a diagnosis is unclear, and radiography should rule out other diseases that may produce similar symptoms. Look, to get things approved, a lot of times you have to have demonstrable evidence on imaging that there's a tear there, whether you're talking about a knee problem or you're talking about a shoulder rotator cuff tear. I mean, the gold standard is an MRI showing a complete tear through the, say, for example, a supraspinatus tendon. So these guidelines are really idiotic. And I think they're counterproductive. I mean, when they say, and just think about it a second, When they say that therapeutic interventions are primarily aimed at reducing pain and improving joint function, yeah, if a guy's saying I can't hardly walk and I'm hurting like hell, what are you supposed to do? Say no, we have to facilitate improvement in joint structure. How are you going to fix the structure of a joint that's worn out? It's got an ACL tear or meniscal tear or lateral or medial collateral ligament damage. I mean, I seriously wonder if these people ever were clinicians and in the field dealing with actual patients, or if they just jumped from school to crunching numbers. I mean, it's ridiculous. And, telling somebody you just need to exercise, a lot of that, I believe, comes from the insurance companies whose theories, because if something happens, they're having to pay. Best is less. In other words, don't do anything for them because it might cost us some money. And heaven forbid that we should pay out money, even though that's what we're supposed to do because we're an insurance company, and in the event that you get hurt or sustain a loss, that's what we're supposed to do. But we don't want to do that because we want to make lots more money. So thanks for putting up with my rant. Thing is, I put myself in a patient's place. If my knee was swollen up and it was hurting, I could hardly walk to work, couldn't sit there, do my job all day, went to a doctor and he goes, buddy, you're really too fat and you're really out of shape. Why don't you go exercise and lose some weight and get out of my office? How about it? I don't think you're doing justice to the patient. And I certainly, as a chiropractic doctor, am not the first one to say, pill for every ill. But sometimes people need pain medicine. The pain is not the problem, but however, that's often a limiting factor. And in a lot of people's case, lately we've been seeing a lot more people who commit suicide, but a lot of people who are in chronic pain more than 6 months, that's unrelenting and interferes with their quality of life. A lot of people kill themselves because they can't stand the pain anymore. So the last thing that you need to do for someone severely depressed, overweight, in a lot of pain is say, hey buddy, you're fat, you're lazy, get your butt out of my office and go do some exercise. Lose a few of that pounds of fat, by the way. It's really not being a doctor in the true sense of the word, in my estimation. So that's my rant for today. And if you're a patient, I hope you appreciate that at Baker Chiropractic, we put you first. We put the care back in health care. We're located across from the courthouse in Longview, Texas. And like I say, I've been a doctor since 1989. This is my 25th year. We've been in Longview since 2005. So this is our 9th year. So anyway, have a great day. Enjoy your Friday. Bye.